Today, we are very fortunate to be joined by Professor Dympna Waldron from University Hospital Galway and Dr. Vlad Gavri, who's flown in from Cologne, to discuss the medical cannabis programs here in Ireland and Germany. When did the program start? When was it initiated in Germany?
So in 2017, there was a law that said doctors are now allowed to prescribe medical cannabis to patients. Already before, there were exceptions that you could give as a doctor medical cannabis to patients, but it was a big mess because all the paper that you had to fill and so on, there weren't many doctors that wanted to go through all this bureaucracy, so patients still used the illegal way to get to their medicine and self-medicated. Since 2017, the numbers started to increase, but we have many issues with reimbursement. I give medical cannabis to patients who tried a lot of stuff like sleeping pills, benzodiazepines and so on, and they don't get any benefit out of it. So I give them medical cannabis because they are telling me from self-medication it worked. Okay. So I have a talk with them. It takes up to 1 hour. I listen to them, they explain it to me, and then I give it to them, and I really closely monitor them with video calls. They get back to me with emails. We have a platform included where we have something like a message tool where they can ask questions, where answer. It's all for free. So it's a service for us because I want patients not have the feeling that they are left alone after getting the prescription. This is really important to me because most of the doctors, unfortunately, they do it like this.
And tell me, Vlad, thank you. What are the current what did it start off with the program? What medical conditions were approved for the program in Germany?
So also now, like after 5 years where the program has been here, there was something like all the data was put together and evaluated, and first indication is chronic pain, by far. So it's chronic pain. We have nausea and vomiting, chemo-induced nausea and vomiting, certain types of epilepsy, Lennox-Gastaut syndrome, for example. With kids, also multiple sclerosis with really, how do you say, like advanced spasticity.
Spasticity, yes. And Professor Waldron, the Irish program we know started in 2019, and it was financed by the HSC in July of 2021. So it's relatively new. How is the program doing now when we're maybe 6 months in?
Can I say that my area being more cancer, and I have a background of being involved in the past in chronic pain, so I know quite a bit, but I wouldn't be talking for neurology. Yes. So I know my colleague neurologist would be very involved in trying to get cannabinoids for MS and epilepsy, which is now an indication in Ireland, so I can't talk to that. But I can talk to what's happening with the access to cannabinoids for nausea of chemotherapy and cancer first. And to me, it's a disaster. I couldn't believe, because a year ago, I applied to get our risk assessment department in our hospital in Galway, because we were a big cancer centre. We cover from Donegal down as far as Ennis. And I wanted to get Sativax, which was the available spray, a small dose of THC and some CBD, which are the two drugs kind of shown to help with nausea. In fact, could I say I was involved in 1984-85 when I was an intern in a study on CBD for nausea in Ireland, in Galway, which is published. So this is an old drug that's been around forever. But when it was reimbursed, I was so excited that we could use it until I saw the form that has been given out to doctors, and they're only allowing neurologists, which is fine, to prescribe medical cannabinoids, and oncologists. Now, palliative medicine physicians, certainly in our service, prescribe all the opiates, all the symptom control drugs. We see our patients for years, on, off, in and out, through their illness. So this was absolutely devastating that we realised the drug was reimbursed in the community, but we can't prescribe it. Now, I was told with these emails, sure, you can become an outlier, you can prescribe. I will not be an outlier. The reason I will not become a sole applicant to prescribe cannabinoids for nausea of chemotherapy is because if I'm away on a holiday for a month, who follows the prescription? There's a risk issue and a governance issue if there's if the whole of palliative medicine in Ireland isn't allowed to prescribe cannabinoids. Now, for the few that we really wanted to give it to, I supervised and helped my colleagues in oncology, but they couldn't believe it, like that I'm sitting over them, sending them emails, this is the dose, this is how it works, I've studied Australia, American, Canada and Germany, and here's the information. Yeah. They don't have the time, because like their area of brilliant expertise is chemotherapy and immune modulators and all the exciting new advances in cancer, which has been phenomenal in the last few decades. I leave all of that to them. I say in my mind every day, he who knows not, he knows not, is the most unwise of monkeys. I know what I know. They know what they know. I know these drugs, opiates, I know quite a bit about cannabinoids, but I am the safer person to prescribe it because I have a background in all of this. So that's been a devastation. Can I say another thing? Because this is a huge issue for me. I remember when I was trying to get it passed in our hospital, because it's a big deal, and I think we're the first hospital that actually passed it in Ireland, to use it as inpatients, that it's only prescribed for patients who are on chemotherapy for gastric tumours and cancers of the gut. The thing is, how many patients that I see have had chemo, aren't able for it anymore, want to spend their time at home, but want to eat and want to enjoy their food. When I was on the phone making multiple calls till late at night trying to sort this out, my daughter was digging into a big pizza. And when I came off the call, she said, Mum, I never thought about this, but it'd be terrible to have cancer, but by God, wouldn't it be awful to not enjoy this pizza? Yeah. I don't think people understand what anorexia means, anorexia of cancer. Just means the smell of food makes you, there's nausea, there's vomiting. I mean, I divided into each section of symptoms: dry mouth, coated mouth, thrush. When a person has no appetite because of cancer, it's awful. And I remember somebody saying to me once, I didn't want a feeding tube. People don't want feeding tubes. They want to enjoy the best quality of living, enjoy a little bit of a quiche or something tasty. And I remember this person said to me, I don't want a feeding tube, but he had terrible symptoms. Please just allow me enjoy my food before I die. He had 4 chips a week before he died and he loved them, and that was everything. So I don't think people understand. I do, because I see it all the time. I think it just hit one of my kids when she heard me on the phone digging into a gorgeous pizza. What would it be like if that pizza tasted like cardboard all the time and you had no enjoyment? So I cannot understand why cannabinoids for anorexia and nausea, say, of advanced cancer isn't allowed for those people who are not fit for chemotherapy anymore or have chosen to give up chemo and have the best quality of time at home. It makes no sense to me. It makes no sense. About chronic pain, I just don't understand it at all because it isn't in Ireland reimbursed. Did you know that? They haven't allowed. Now,
we're hoping that it's going to be added to there's a review currently, going on, and we hope that the findings of the review that will be published, I think, early in the new year, will include chronic pain, neuropathic pain, maybe 1 or 2 other medical conditions.
Can I say something on that? Because I've done decades of chronic pain. Why? Because there was only 2 of us in the West in the beginning, 1 chronic pain, 1 me. And, over the years you get back and forth, a lot involved. So I did an awful lot of cancer pain, an awful lot of, difficult, complicated chronic pain. I didn't want to, but I did. And you see the difference of apples versus oranges: cancer pain, chronic pain. Chronic pain is chronic pain because it's impossibly difficult. Cancer pain is actually quite controllable, we'll talk about later. But I was at a meeting in Denmark last week, and there was a lot of Israelis, huge experience in using cannabinoids for chronic pain, UK, Germany. But I asked the Israeli doctors afterwards, they were saying to us that the reimbursement in Israel, still, even though they're using lots of cannabinoids, is first line, second line, the usual drugs, and then third line, opiates, fourth line, cannabinoids. That makes no sense to me, because I know from all the experience in the world that we've seen, opiates do not work for chronic pain. You may be stuck in a corner where you have to use them sometimes, And that's happened for everybody, but you keep them safe as best you can. But technically, opiates have never really been shown to have benefit for chronic pain. Cannabis is a lot less addictive. Why is it left fourth line? It has addictive potential. We all know every one of these drugs. But I can understand how a protocol will say third line opiates for chronic pain. We all know it shouldn't be in the mix that much at all. And cannabinoids are put fourth line.
So just with, I suppose, Dr. Vlad, with prescribing in Germany, just bring us through the whole process. We know in Ireland it's a consultant-led onboarding. The patient has to be registered on a Cannabis for Medical Use register by a consultant and then monitored by the consultant. In Germany, the model is a little different. You're a GP in Germany. So will you just walk us through how a patient goes from not having a cannabis prescription to being prescribed cannabis?
Well, there are two ways. Either he or she's going to his GP, he's working with the insurance companies and he's trying to get the reimbursement. This is way more difficult because for this you have to have the indications, to have all the available therapies gone through, tried them out, opioids and so on, everything for the chronic pain. Or you go to a private clinic or whatever, to us, for example, to our telemedical platform, and there you can just get an appointment when you have a diagnosis. Or if not, you can come to us, to our clinic, and then I can do an anamnesis, a physical exam, everything, and put you a diagnosis. This also takes like 1.5 hours. After this, most of the patients are also telling me about their experiences. I have many patients who have experience with cannabinoids. I just had one 78-year-old who didn't have any experience. He never even touched cannabis. He didn't know how it looks like. So with him, you have to be really careful. But the other ones, they're telling me about it, and then we are trying to find the right dose together. What I don't like is when a doctor is telling a patient what to do, exactly what to do, and not fitting him into the progress. Because for me now it's different. Normally patients go to a doctor and the doctor knows way more about the drug than the patient. But nowadays about cannabis, a lot of patients know a lot about it. So I put my expertise about how it works. I tell them about the endocannabinoid system. I educate them on it. So they also know how to maybe counteract tolerance, psychological dependency and so on. I tell them about it. And then in the end, if I have after 1.5 hours the picture that he's fit to use cannabis, I prescribe it to him.
Dympna, would you believe a system similar to the system in Germany would work in Ireland, where that you'd have a GP-led system, where that the GP is, with the patient day in, day out, and it's been supervised by a consultant? Do you think the system that's currently there, where it's consultant-led only, will work going forward?
I think a team is always better, having a team. Yeah. And I totally agree with you. And I was almost mind when you were talking, because I always say to our team, and I say to multiple talks, if we're led by our patient, we can't get it wrong. I engage the patient all the time. And actually what I say, this is say with cancer pain and opiates, because opiates do work for opiate responsive cancer pain, which is 70% of cancer pain, without toxicity, tolerance, addiction. So I always say to the patient, please ring the bell. I'm not going to ask you a number, but I'm going to ask you to ring that bell if you've pain. We'll have first line, second line, third line nurses. We'll keep it safe, but you're the only one who feels the pain, so you're in charge. So we completely engage. Our patient is the leader. And until they have zero pain, that may go up, that may go down, it's all a dynamic process. But by putting, it is so empowering and it's so important, because it's the truth, because a subjective symptom like pain is something that a person just wants to be free of as best possible. We can't guarantee that with chronic pain. We can a lot with cancer pain, not all the time. But by putting the patient in charge, it really helps. So if we have the patient in charge, we need backup with the right physicians, the GP, the consultants. They say for us, for people with difficult cancers, supportive care in the community, palliative care at home, supportive care, not palliative care, not end of life, supportive care, living. but we always engage with the community GPs. It's a team.
I suppose with meeting with consultants, I think the biggest challenge is the education around, you know, the dosage, you know, the titration of the product. You know, day in, day out, we receive calls and emails from patients looking for some sort of support. And these are the challenges. It's just the education, you know, and I think that's the fear factor in Ireland. Do you think?
Sorry, Richard, I don't think it's just in Ireland. I think it's across everywhere. Because, and you know why that is, because the research is flawed. But can I just say here, I'm sure you agree, all the research is flawed worldwide, because how we measure a symptom such as nausea, pain, and that it can't be measured in a straight line with a questionnaire at every single output. So what's wrong in medicine? I mean, I'll give you an example. I qualified in 1984 in Galway. The only sentence I got my whole 6 years of training on opiates in cancer pain was, opiates are the best painkillers known to man. They cause respiratory depression and death. Use with caution. That was the only education on everything to do with opiates in cancer pain and anything. So the education in the 80s was non-existent on opiates. Now it's huge, you know, we give loads of lectures all through. It's a knowledge base that's needed and better research, and then doctors will start to incorporate the endocannabinoid system into pharmacological lectures and into, you know, talks on pain control or nausea. Do you agree?
Yeah. We need more research. Yeah, it's true. This is what I also hear from doctors, that I want to not convince. I just want to like show them that there is another possibility. Which, in my opinion, if you compare the side effects, also it's a joke with cannabis. Of course, there is this tendency from especially young patients to misuse the drug. But this is there for every substance, in my opinion. With alcohol, with everything, has the potential to be misused. And I always hear, but you are telling me, your patients are telling you it works, it helps, but there is research missing. And I'm also always telling them, because when I went to the Cannabis conference in the end of September in Basel, there was a patient council. And this was for me the best part of the conference, because they said, we also hear and we say there needs to be more research. But until then, what about us? Are we not enough evidence? And this is what I like. It is, of course, more time consuming to listen to your patient, to take the time for every patient. But if we would do this, then more patients would benefit from it. Because what I really, I don't like to use the word hate, but what I really don't like is in medicine nowadays, those questionnaires they are put.
Yes.
Because for me, they are too general. They try to generalize everything, so studies can be made by this. It's good to get an overview, but it's too less individual. And this is the problem in nowadays medicine, my opinion. I'm still young, I don't have so much experience. But what I also hear from my friends, family and everyone is, when you go to a doctor, it's like when you start talking, after 5 minutes they can formally see that he shuts off, he heard some keywords, and for him in his head, the diagnosis is done. He doesn't even listen to you anymore. And then after 5 to 10 minutes, you're out, next. And he's happy if you don't come back.
And that's where the research is flawed, because you cannot. I'll just give you an example of, say, quality of life. I've 34 years done examining quality of life, and I hope we've actually connected to the individual. We call our methodology introducing, say, a student to the person, not the patient. We want them to see the human being, the whole global part of the person. But in the questionnaire, I had to use the questionnaires. And questionnaires, for those who don't know, are just these basic questionnaires that are very good to get kind of certain bits of information. But we say the ORTC, which is a cancer questionnaire on quality of life, it asks questions like, can you take a long walk? Can you take a short walk? How are you doing your household tasks? And the patient's paralysed in the bed. The questions are so inappropriate to the patient at that point of time in their illness. And that is, they have given up the fact that they're not going to walk. You know, they know that, but they want to maybe connect with their child they haven't been getting on so well with. And what we want to do is try and get medicine to capture that. And we can. And scientifically, we've been doing that. And like America's really picking up on our research. But I was asked, just out of interest, I was asked to give input to a European group. We'll probably get a couple of million, if not more, research funding to look at patient-centred research. So I spent a good hour on a Zoom and put everything into it, talked about this, validated methodology that links to the person. I'll be presenting it later, a little bit of it. And guess what they said the next day to me? Sorry, take too much time to be spending time with the patient. So my view is you'll pay a fortune for an MRI that takes 40 minutes, but you won't spend 10 minutes sitting with the person and asking them what matters to them.
Yeah.
I suppose again we a little bit of experience in as we're a healthcare company and a technology company as well. Software is taking more of a prevalent role in collecting data, patient data, and we've seen we also have an app ourselves that we designed specifically for the Irish consultant. That they can track the dosage, the treatment, any side effects that may occur with the patient. But on a larger scale, we're seeing it happening now with real world data, citizen science, much bigger studies happening, in tens of thousands of patients, where the patient would have an app, like everyone has an app on their phone, multiple apps on their phone. And I think it's fantastic that you can, you as a doctor, you can have a high level overview of tens or hundreds of your patients that are being prescribed or on a treatment of cannabis. And equally for the patient that has the mobile application, that they can quite quickly record their session, can record their side effects, if whatever the case may be. Do you think something like that, do you think the software is key to the development of the medical cannabis industry, that people can use software to track patient data rather than the questionnaires that you mentioned earlier?
Oh, I totally do. But I think the important bit is the questions and how they're asked and what you put. And I think that's, as I was saying to yourself and Shirley, that's what, when you're 34 years at the bedside, you know about what's valid and what isn't valid. It's how you direct the questions to the patient, and kind of get the patient interactive in the app. And I think that's very doable. And it's not something that's just based on a smiley face or 0 to 10, because 10 can become 100. It's actually way more complicated than that. I remember when I was doing my original MD thesis, I was in the RCSI and there was a great epidemiologist there. And I'd never really known this, but every time questionnaires were set up, it was kind of around how a questionnaire is set up to go to basically fit to the language of a 6-year-old child. That there's an awful lot in questionnaires that has to be very basic. And I think when you're looking at, say, chronic pain, cancer pain, or nausea, it has to be a lot more intuitive and deep for the patient to get engaged in it.
Well, I think apps are really good there, also in monitoring and so on, but I wouldn't like an app where you can choose as a patient to just click on something like multiple choice. Like there needs to be for sure a box where he can write his own words also. Yes. And this would make it, again, more time consuming for the doctor to re-evaluate it and so on. But especially for the young patients, nowadays, like, everyone is using the phone, and to have it also on the go when you are traveling and everything, it's a really good tool. But you have to include, when you put the questions, doctors like her with experience who know which questions you have to put. This needs to be done.
Yes. Yeah.
So
I suppose.
And could I just say, yes. Richard, red flags.
Yes. Red
flags are brilliant in the app. So if because we know what the red flags are. Red flags for uncontrolled pain, red flags for addiction, red flags for, say, constipation with opiates, we know, so that an app that actually has a value to the doctor, that has a red flag system, could be very helpful.
A traffic light system, I think, is a similar system where it's like a traffic light system, like green, amber, and red. Yeah.
Wouldn't you agree?
There is a really good website, druginteractions.com, where you can also put medical cannabis, and it shows you, like in red, orange, and green, the interactions also with drugs, because it's metabolized in the liver with the CYP enzyme and so on. CYP, I say CYP. So there are many inductors and inducers. So you have to be careful with this also. And many doctors like that I know who also prescribe medical cannabis, they ask about any other drugs they take, but they don't consider also herbal stuff, because also herbal stuff can influence like the metabolism and everything. So this is missed a lot, and this website is helping a lot. I use it for every patient because it's there, it's available, it's fast. Why not?
Yeah. So I suppose right now we have two extremely different markets, one in Germany here and one in Ireland, where the German markets is going into recreational, which is a whole different area. And then in Ireland, I suppose a question for you, Dr. Waldron, is how do we progress from where we are at the moment, which is 20, 25 patients on the MCAP, maybe another 60 patients on the ministerial license. How do we go from that number to the real number that where we have tens of thousands of Irish patients in need of medical cannabis treatment? What do we need to do? What needs to change in Ireland for that to happen?
I think webinars like this be very helpful to get the public to know what the complexities are around prescribing, and that there are people like myself who know these drugs have a role. We want to keep it safe, we want to keep it appropriate, but we're not able to use them, so it's a bit frustrating. I think having think tanks, getting that MCAT, whoever those, the people who make this law, I don't know where the law came from, but I mean, I'd love to sit in a room in a round table with the experts around a table to kind of say, why did this happen, or who made this decision?
Which is part of the clinical review from 2017, I think, is it?
You said that there's a clinical review coming in January. Okay, it's on Friday, but why? How are the people who really want to be engaged in this engaged? Because there are some people I know, some of my colleagues wouldn't be that interested, but they wouldn't mind if I led the way and took the risks and then published a few papers and they followed through. That's okay, I don't mind that. That's how a lot of our specialty has worked, because it's a very new specialty. And I might try ketamine 30 years ago and still using it. We're publishing on it, So yes. My colleagues then said, great, so I don't have to be scared of it. Tapentadol, we're using an awful lot. We're about to publish on it. Methadone as a piggybacking for opiate-induced hyperalgesia. We published on that in the BMJ a few weeks ago. So people already in Europe are picking that up as practice update. So I don't mind being kind of one to take the responsibility, but I'm not allowed to prescribe it. So actually, 34 years training and experienced, and I've never even had a break to have 4 kids, so I have worked at the bedside.
Prescribing opioids, but you can't prescribe...
Prescribing the most complex drugs, ketamine, opiates, and I think what a lot of people don't understand is in, say, something like my job, we also deal with every system, every age group, every disease. 45% of our patients have non-malignant conditions, and 91% of our day's work is helping people to live and get well and be at home, not die. And everybody sees us as end of life. So our job is very engaged with every system. So we do an awful lot with nausea, vomiting, obstruction, drugs like octreotide, and we've a huge, we've a lot going on. And somebody like myself is interested in taking responsibility, looking at where cannabinoids work. And I'll tell you why. It's, Professor Anthony Dickinson, Professor David Vane, they're super guys. Professor David Vane is the expert in the world on experimenting, they're looking at the animal studies. And then Professor Anthony Dickinson is brilliant on all the pain pathways, opiates, but also on cannabinoids. And we invited him to a meeting we held every 2 years called Crucial Baha, the Pulse of Life. And we asked David to talk on the science of animal studies. And then we asked Tony Dickinson to speak on the endocannabinoid system. And what he said really struck with me, because I always say this to patients who have cancer pain that's opiate responsive. I will say to the patient, that pain is there to make you see your doctor. It's got a protective mechanism. You need back pain, go to see your doctor. There's something in your bones, get the treatment. Then is that our bodies actually are tailor-made with opiate receptors to get pain relief from that pain. Chronic pain is different because the pain becomes the disease. But cancer pain, people are not bad, they haven't had the bad luck of having both genetic chronic pain and cancer. It's not common, it's very rare. But then if you think of the endocannabinoid system, why do we have 7 endocannabinoid pathways in our body? They have to be there for a reason. And that really strikes me. it's similar to what I've been saying for decades to patients about opiates and cancer pain. And our endocannabinoid system just hasn't maybe had the volume of research that it deserves. But we've 7 endocannabinoid pathways.
Yeah.
They have to be there for a reason. Our bodies don't have pathways for no reason. Does that make sense?
Yes.
And Dr. Vlad, I suppose, just tell us a little bit about the market again. What's happening in Germany? We have a medicinal cannabis treatment, and now we have a recreational market coming in 2024, I think. How is that going to change the landscape in Germany?
What I know, like I believe that the medical cannabis market will still be there, because there are, of course, patients who now use medical cannabis for reasons not really medical reasons.
Okay.
They use it to be legal, to be safe, because it also like has a huge impact of the quality of your life when you use cannabis, also for recreational use. But you always have to think about, any time the police can stop me and I can lose my license to drive and so on, then I will lose my job and all this. So also psychologically it has a huge impact. So they use it for this. Those for sure will go to the recreational use, but the patients who really need it for like whatever sort of reason, like pain and the indications, they will stay. And there are like polls done in patient groups that I heard of from patients, that they are asking, when the recreational use is legal in Germany, will you change to recreational market?
Yes.
And 60% of them said, no, I will stay and be a medical patient, because they want also doctors to be at their side if they have a question, to have a person they can ask about. In Germany, they are now talking about, at the legalization process, about this specialist stores, like specific people working there. And I'm asking myself, who are those people? Who are those people? What license do they need? Which education do they need? Do they have to have a medical background or not? Because in the end, which I don't want, is that there are students working there and giving recreational cannabis to patients, or to also recreational users, which is wrong.
Okay, yeah.
I understand that all the process is taking time, and on the one hand, I'm thinking like, do it faster, but on the other hand, I see that they really care about how it will impact, because the decisions they do now are not only for Germany, it's whole Europe that will follow afterwards.
Yes, yeah. What's your take on the recreational market that's happening in Germany and potentially come across all of Europe in the next 3 to 5 years?
A disaster. I actually don't think it should ever. I mean, that's like telling everybody you can have an opiate, and I just don't see the reason. I mean, I'll just tell you an example. I was given a talk in Canada. I arrived in Vancouver the day they legalized cannabinoids. And at that meeting, I met the most fabulous nurse who was just wonderful, high-powered, high-achieving, lovely family, 2 sons, 1 in prison, 1 just out of prison, 7 funerals she was at. What did they all start on? Cannabinoids. Cannabinoids is a gateway drug to the bigger drugs. It doesn't matter what anybody says. These drugs are there, like I said earlier, our bodies have these receptors, because if there's cancer causing opiate type pain, the drugs work on it. It's like a sponge, it's soaked up, so you don't get the tolerance, the addiction, the overdoses, all of that. Then you have cannabinoids, and they do, but they all have a dopamine issue when you're using them without a problem, without a physical problem. And I'll never forget that beautiful nurse. It broke my heart. And that's what I saw the day I arrived, cannabis was legalized. And that was before it was legalized, so God knows. I'm very frightened of it.
Yeah, there are those experiences, but there are also other experiences, because what I see, what also patients are telling me, is the anxiety. That is like, everyone has anxiety nowadays, about especially now with the crisis, financial crisis and so on. So they go through life with always thinking about fears and what can happen next and how do I survive and all this. And there, in my opinion, also people can use cannabis to get a certain level of cannabinoids in the system, when they have a deficiency in the endocannabinoid system. Because I also experienced depression in my life, and I know that when you are in this moments when you don't see any light and so on, that you need something to take you out of this circle. And there are experiences from patients, even mine, 3 of them with depression, they say, whatever I do, whatever antidepressants I took, I tried everything, it doesn't help me. When I take cannabis, it's like I leave a heavy bag behind me and I can go through the day. And because you said, the pathways and so on, cannabinoids, they also get, connected or bind
Yes.
to serotonin receptors and so on. So it has an impact on those illnesses like depression, anxiety and all this. But the recreational market, also there, I also see dangers. Because there are people, like you said, they don't have any issue, no deficiency in their endocannabinoid system, and then they go. But in my opinion, we can't, or the government, in my opinion, this is only my opinion, it can't tell people you can use, now I'm going to alcohol, because this is legal everywhere. Everyone can drink it, everyone has access to it. And they drink it and this is okay. But then they say to patients, a plant that is you can plant it everywhere, you can get it, you are not allowed to take it. In my opinion, this is wrong.
Yes.
Plus also that it's a gateway drug. What I hear from patients, and in Berlin, my brother's living in Berlin, next to a specific park that everyone knows, if you just go there, you will find cannabis. And then you meet people who don't just have cannabis, they also have other stuff. Plus what they are interested is just to get you hooked on cannabis, to put in whatever, heroin, whatever, they put spray on it and so on. They just want to make you addicted to it, so you stay with them, and at one point they will introduce you also to the other stuff.
Yes.
So I don't know what is correct here, but
there's benefits as well.
The way it is now in Germany, and this is also what the health minister said, it's not working, the prohibition. It's not working at all. So there is time to change something. If it's to legalize, I don't know. We can only see what the future will bring, but to go the way it's now, I think it's wrong.
Well, we do know, I suppose, the future in Germany at least is there is a recreational market happening in the next 2 years. And I suppose the takeaway from today is that what we need to do here in Ireland is we need to continue education, specific clinics, evaluations for doctors to understand the endocannabinoid system and how to prescribe it. I think we need more prescribers. Right now, as I said, we have a limited number of patients simply because it's consultant-led.
Early onset of education, I think this is really important. To educate students already about, to have it involved in the curriculum.
Yes.
It's really important, in my opinion. It's there since 30 years.
But we do need more research, because all doctors are going to say is the p-value wasn't enough, right? And that isn't that true. That's where. But I know how the research could be changed to capture the p-value that we're seeing at the bedside.
Thank you, guys. I look again for our first meeting, first webinar. I want to say thank you to Dr. Vlad for coming over from Germany, and specifically thank you to Professor Waldron, who travelled down from University Hospital Galway. And I look forward to seeing where this goes, and look forward to seeing where the programs expand across Europe. Thank you.